Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And our guest today is Dr. Alex Butler. He's Chief Product Officer at River Records. Welcome, Alex.
Hey, John, thanks so much for having me.
Yeah, thanks for coming on as part of our ongoing series of ambient clinical voice, AI medical scribe, AR, EHR assistant. I'm not sure what the branding is today, but that
Nor are any of us. We're still kind of figuring out as we go.
I think AI medical scribe's starting to win, but we'll see. But
Yep.
either way, before we go there, tell us a little bit about yourself and River Records.
Yeah, I'm happy to. So briefly about myself, I'm a pediatrician based in Boston, and actually I'm also serving right now as one of the chief residents at Boston Children's Hospital and Boston Medical Center. Before
Nice.
that, I've been involved in health technology forever. I actually got a master's in clinical informatics during medical school. And the funny way I found River Records is I was kind of looking for what my next project was going to be, experiencing being a doctor for the first time. Read a fascinating paper on a hospital night shift. Actually, I've never been able to sleep in the hospital overnight. Written by these three doctors about could you build a healthcare system without notes? And I thought that was such a fundamentally cool idea that I emailed the lead author thinking, oh, this is some accomplished guy, he's never going to reply. 6 hours later, who is now our chief technical officer, Jackson Steinkamp, replied, said, oh, we'd love to chat. Had coffee with him and the now chief medical officer, I think 2 days later, Jacob Kantrowitz, and that was it. Since then, it's been really a research project of just asking these questions. How would you build a health record system that doesn't use notes if you could start from scratch? And this year, really in February or March, we decided to see if we could make a real run for it to be a company and get it out into the market.
That's awesome. Well, we always talk about the paperless environment, a noteless environment. That's
Yeah,
fascinating. I think that's
it's what we
next
want to
level.
be, even if it's hard. It's what we want to be next.
Yeah, that's cool. So tell me the story behind River Records. You gave a little bit of anecdote there, but tell us, how did River Records come about? It sounds like you really went all in earlier this year, but tell us more about that
Yeah.
story.
Yeah, so the full story actually starts years and years ago. Three of our co-founders, I mentioned Jake, Jackson, and Abhinav Sharma, who's right now our CEO, met in medical school, really had bonded as friends over studying over tech projects, and since finishing medical school, going through residency, and now each of them being family practice or primary care physicians, have always been doing technical projects. Some of their early groups together was looking at incidentalomas. They were doing some data quality research at Boston Medical Center, and then really dove headfirst into this idea of could you get away from notes? The fundamental idea really being are notes the best way to store medical information? I think our team's feeling and speaking to other providers, the general sense is probably not. It was good when it started, when we were doing handwritten paper documents. It was convenient. And I think when we moved to electronic health records, instead of really pausing to think about what's the right solution, we kind of just kept going. We converted notes into more or less Word documents and haven't really looked back from there. So since then, that paper was published in 2021. We had been building kind of internally a guerrilla tool, if you will, to test out different ideas. How could you build the system? How would data interact? Um, we had a lot of late night meetings on Tuesdays and Wednesdays, had a beer and just talked about ideas. And as ambient medical scribes, as you said, became more popular, we saw a window to take this idea and actually see if we could bring it to clinics, bring it to providers, save them time, and frankly, go a step above, I think, what a lot of other scribes are doing today. And we've had a pretty successful start. We're only 6 months old, and we're already working with a number of providers across the country. So I think the reception's been pretty strong, and we're excited to keep going with this idea and see how we can build this out into even more fleshed out systems.
That's awesome. How does your solution compare to, the plethora out in the market? Everyone go check out healthcareittoday.com, the right side, ambient clinical voice companies. You can find a whole slew of them. But how do you think it compares? What differentiates you from the other companies working in the
Yeah.
space?
First of all, great plug, very seamless. Um, Second of all, I think, like you said, there's a lot of ambient medical scribes right now. It's a technology that is hugely impactful in the clinical space. You finish your visit, your note is done for you, small tweaks, and there's tons of papers now showing the benefit and how much that helps at scale. The reason and the difference that we really see in ourselves is we're questioning this idea of is the note, again, the best outcome of those types of tools?
Mm.
If we look 5 years in the future and really big companies like Nuance's DAX, or you look at things like a bridge or really large centers, if we continue to use those tools and they all generate notes, are we going to pick up our heads in 5 years and go, wow, we have a faster note writer? But I still have notes, and now I have to build another system to read the notes that I've written back to a human. And is that really the best case for these types of systems? So what we've tried to do at River Records is a little bit different. The entry point is very much the same. You can use your phone, your laptop, your desktop, any microphone to record your visit. It listens in the background. You don't have to treat it like a dictation system. It just listens to the visit as it goes on. And then where we differ is when we start to generate information from it. The first step that we do, and I hate to use verbs that personify these systems, but we've tried to train our algorithms and our system to really read the transcript and interpret or identify the problems, the conditions, the symptoms you were discussing.
Mhm.
Kind of gives you as the clinician a chance to review, oh, yes, this is a problem I talked about. No, this isn't really as relevant. And then once you agree with what's been written, you basically send it back into the system as a set of instructions. And now what we do is we go to the transcript and pull out information from the transcript relevant to those problems. So if you and I had a visit, let's say we talked about high blood pressure and ankle pain because you were playing basketball and rolled your ankle. The fact that you rolled your ankle probably isn't relevant to the hypertension, and the fact that you take atorvastatin isn't relevant, vice versa. So we pull that information out under the heading, under the context of the problem, and ultimately create what we're calling narratives. As I see you the second time, I continue to do this. I continue to do this. So your hypertension narrative not only contains relevant information from the first visit, but adds relevant information at the second visit and then the third visit. And now, as the provider, I can really easily see A, all the conditions, the symptoms, the items we're managing together. How have they evolved over time? And I think in the clinic, that's a huge cognitive burden we get to take away from the provider. As a pediatrician, when I'm seeing patients in the hospital or in clinic, there's always probably 10 or 15% of my brain kind of always turned on for sorting what I'm hearing. How does this fit into other pieces? We don't want to take the decision making away from the provider. That's why we all became doctors, became clinicians, but allowing the scribe system to help with that organization, storing it in the right way, managing the problems, managing billing, doing those pieces that I don't have to think about. It takes, I think, the next step further than current scribes out there right now. And we have a long roadmap of other pieces we get to do with narratives that I won't bore you with today. But that type of organized data opens up a ton of doors of new product ideas, new additions, clinical decision support, lots of different things we can jump into.
Yeah, no, I mean it's interesting all the opportunities, and that is a different way of looking at it. And talk to me more about the
Yeah.
workflow because I that sounded, I mean, yeah, the front end it sounds similar, right? You
Yeah.
have any device, it's listening ambiently, but then it sounds like you're taking some clinician input to kind of before generating the full note, you're kind of identifying the information, then having the clinician kind of give their feedback before. Is that the workflow, or what does the workflow look like for a clinician? I mean, obviously, it's you hit record, get patient consent. Everyone does
Yep.
that now.
Yeah,
He
exactly. The entry
listens
point is
ambiently.
identical.
Yeah,
Yeah.
but then as they exit, they have to approve or they acknowledge things. Or talk more about that workflow.
Yeah, absolutely. So the way we've described it is really as a clinician in the loop. Like you said, the entry point is the same. Start recording, get patient consent, record the visit. In a typical scribe system, usually when you say stop recording, it begins to process a note, essentially rewriting the order of your transcript into a structured SOAP document. Our system is different, one, in that we actually allow multiple areas of audio entry or multiple audio files. An example being maybe you're coming in to see me in clinic and I'm pre-charting or prepping my documentation ahead of time. I can record prior to your arrival, then pause. I can record during your visit. And then just to make an example, let's say I'm thinking of a differential that includes some diseases that are not great. I don't want to discuss it yet on our first visit, but I want it in my note. I
Mm.
can then make a third recording after the visit, and that doesn't disrupt any of the workflow. Then, like you said, you start to generate your note. Really, the system will identify a list of conditions, a list of problems, and then you, as the provider, would only have to review them and basically make sure it's accurate. So you're not writing anything down. You don't have to build this list for you. It's just proofreading what the system identifies for you. It allows you to be a little bit more customized. Another huge value of this step is it also knows the problems that we have talked about as a patient and a provider before. So if you and I have been talking about hypertension, it's going to pull that in. And then when it goes to generate all of these narratives, it continues to build on information we have previously and information that's new. So what you end up with is, in the simplest sense, a problem-oriented document where information is broken down by the problem or by the condition. but it's all contextual. It's surrounded by stuff that's relevant. When we're integrated with an EHR, we can pull in lab values and radiology reports and consult documents. And where our system, I think, really takes a step above the competition is especially in the world of primary care when we're doing chronic disease management or complex care, this ability to document while simultaneously managing my problems, tracking these conditions, seeing what's changed from my last visit to today without having to go read a series of notes is a really big step forward in how I, as a provider, interact with the data that I'm already collecting.
Yeah. No, you're right. I mean, so far the solutions have been, let me capture the note versus how do I rethink the model of care and consumption of the notes that are generated,
Hmm.
the notes that are previous, et cetera. There's some people working in that space
Yeah.
separately, I think. But
Hmm.
yeah, that's really an interesting differentiation. This next question, we do out of because we've done it with every vendor, but
Sure.
it feels a little dated now.
I'm ready.
I'm interested to hear your response. Although you already said doctors in the loop, but beyond
Yeah.
that, is this fully automated with technology? Are there humans in the background?
Yeah.
I assume you're not doing any background scribes like some companies.
We are not. We are not. We found that one of the values of a fully kind of automated pipeline like we have, and like you said, we're calling it, clinician in the loop, is we will generate everything for the clinician to review. We have found that our testing, it's incredibly accurate. The number of modifications or changes are a matter of seconds at the end of each visit as compared to minutes or hours in some older school notes. But the value really of an automated system is it's generated, let's call it 10 seconds from walking out of the room to sitting at my computer. It's all done. A number of the other platforms that have historically used offsite or other types of scribes have to submit, wait 30 minutes to a couple of hours. That can be very disruptive, especially if my clinic is running late. So the ability to generate it in real time is something we take very seriously and we'll be able to accomplish with the tool we have.
Yeah, absolutely. You mentioned EHR integration.
Mhm.
Obviously you're 6 months in, so I'll give you a half pass on this answer, maybe. But talk to us about your EHR integration. How are you approaching that? How many
Yeah.
EHRs have you integrated with? Is it working with all EHRs? Talk to us about that.
Yeah, no, it's a great question. So I think it's a two-part answer. The first answer is we're working with an EHR integration third-party company, which means that we can share data back and forth with essentially any health record in the United States and Canada. We have experience, at least with the partner, with 90 plus EHRs, and we're highly flexible with adding new ones. And what that means is, again, let's pretend I'm the provider. I sign on to use our platform. Within 2 to 4 weeks, I can get access to the EHR, see my schedule, get patients automatically updated, and even the cool thing of Stream is use our prior notes for these patients to build these narratives. So when the patient comes back to me for the first time, I'm actually not starting from zero. I don't have to build all this information again. I can import it from the notes I already have, which makes it so much easier to get started. The second answer to your question is really not only integrating or sharing data with an EHR, but like deeply embedding. That's an area where in a number of conversations now with health record companies to build almost a separate tab, a separate environment within their health record system for our platform, for these narratives. And what that allows us to do from an operability perspective is now I can merge my note writing because we can generate notes as well. It's seamless problem list management. As I'm adjusting my narratives, I'm merging, I'm associating pieces, I'm also managing my problem list. We've talked to a number of billing experts who say that 70 to 80% of the time needed for actual billing or doing the CDI queries that clinicians get all the time for basically checking your level of coding is someone who's not clinically trained reading your note and trying to guess what you mean. And by putting everything in context, literally next to the relevant data under the heading of the problem, that workload is dramatically reduced and ends up being a lot faster. So we're pretty confident that directly embedding into some of our health record partners is going to be a pretty cool step for all of their users and a big new addition to how they're interacting with health data.
Yeah, absolutely. I love that you're a doctor, so you can kind of address this next question,
I'm
which
ready.
is what does the clinician have to change when when they're talking in the exam room to make this work? I mean, I'll cover the obvious ones. You can't hear what they're seeing or what they're thinking, so they got to say it, right? Like that's the obvious one. They don't know if you say, if I say I have a pain and point to my right
Hmm.
knee, we don't know it's the right knee or the left knee or whatever, right? Those are sort of obvious, but and this is more about implementation too.
Sure.
How do you onboard a clinician? What do they have to do to change in workflow wise,
Yeah.
to make it successful?
It's a great question. The truth is very, very little. Truthfully, there's not a lot that our clinicians have to change when they start using our platform. Much like you said, using an ambient scribe comes with some of its own limitations. You have to dictate your exam. Sometimes you have to narrate things the patient might be showing you. The only thing that we ask a lot of our users to do, because we do this type of contextual organization, is as they're wrapping up a visit to try to put things in context. So let's say you came in with an ankle pain. I may finish my visit saying, I think your ankle pain is likely a muscle strain. The importance of this is we trained our system very intentionally not to editorialize, not to jump ahead of what the clinician is saying and add more information, because that's not what the system should be doing. It's supposed to organize data on behalf of the clinician, not go beyond. So all we ask a little bit at the end is to kind of wrap up the framework of the visit, as I think many, if not most clinicians already do when they're finishing visits with patients. But other than that, the framework is the same. The editing the note is often similar to what providers are doing on any other scribe platform or in their own EHR. Like any system, you attest or sign the visit at the end of the day. You can share it to your EHR. And now we're also adding the ability to integrate billing codes. So we already have ICD codes. Next will be CPT and time-based. So when I send my note, when I send it to the EHR, not only have I completed my note, my problem list updates, but I've also now finished my billing for the visit, which takes one further step off of your task list.
Yeah. I think you might be giving doctors a little more credit. I've been to too many doctor's appointments where they didn't summarize, but but what's
It's true.
ironic is they were too buried with their head in their laptop
Yes.
to summarize. So
Yeah.
now maybe they could, right?
I hope so. And the other piece I didn't get a chance to add is that we also try to provide a lot of customization. So we have a pretty detailed onboarding process. We like to sit down with all of our users. Here's how to use this system. We'll actually help you bring in your note templates from your existing health record, modify them to fit in our system. The only difference being because we do things on a problem-based level, you can get really specific. So if I'm a cardiologist and I want to see hypertension data a certain way, you can apply it to every hypertension problem you manage. And we can basically bring that in from your old EHR to make that as simple as possible.
Yeah, that's interesting. How do you approach accuracy? I think it's always fascinating. Each company, there's a lot of ways to measure accuracy and quality of
Hmm.
of the note creation, of of all the aspects of it. But how do you kind of look at accuracy? How accurate is the solution?
Yeah. In our, at least internal and our early outside testing, it's highly accurate. We're using now the current state of the model for medical transcription. So it's very consistent. We're adding some kind of highly used specific medical terms, often medications. It's one of the biggest kind of catching points for a lot of these transcription tools. But
Mhm.
really, one of our best ways to measure internally how well we're doing is how does the generated series of problems relate to the saved ones? How much is it actually being edited by the provider? We had a product meeting last night, and we're talking about one of our users who now has 500 patients stored in the platform, and we're noting they make very few changes from the cards bureau, these narratives being generated, to saving and attesting in the chart, which gives us a lot of comfort that what we're generating is highly reliable. And like you said, like any of these systems should do, the clinician has to be in the loop at the end to read and to confirm, make sure it's all accurate. But what we're finding is very little adjustment or tweaking has to be made at the end.
That's awesome. And talk to us about specialties. Do you work for every specialty? Or you've just focused on primary care or what, or other areas? How are you approaching kind of the specialty question?
Yeah, I love that question. I think our tool is uniquely well suited actually to really thrive in spaces of specialties. One of our users, as an example, is a urology oncologist, kind of based in Mississippi, I believe, or Georgia. And what they get to do is they build these highly specific templates dedicated to a problem. So let's pretend that they have a dedicated template card for prostate cancer. They can build that template to be highly specific to one problem. And then when they are generating their information after they've reviewed the list of problems, the output is matched exactly to what they want to look like. So if they want to pull in the last series of PSA or prostate specific antigen levels, we can get it from the transcript or we can get it from the EHR integration. If they want certain sections, a certain flow, the exam highlighted a certain way specific to prostate cancer, they can. But that doesn't mean it's for all of their notes. If they have a BPH or benign prostatic hypertrophy card, that can look different. And that level of customization, I think, is incredibly well suited for specialists. Another really cool thing of our platform is because we hold these problems on our River Records platform, we integrate with the EHR, but really this ability to grow information over time means we get to hold on to some of it. It also becomes highly collaborative. So if I'm seeing my colleague's patient or I'm referring to cardiology, we get to all access the same shared problems. I get to update and modify the shared data instead of starting from scratch. So it ends up becoming a much better source, we think, of information for our patients than having to go through a stack of notes and bouncing around, which, as any provider knows, can take up a ton of time.
Yeah. I want to talk more about the templates. You
Yeah,
mentioned them a few times. Obviously we went from a world of dictation, et cetera, which then led to these templates, right? So we could bill at higher levels. That was kind of the EHR evolution 20 years ago when I started, 18 years ago when I started writing about
yeah,
EMR, right? And it was like, oh, now I can bill for level 4 rather than
yep,
3, which is, because I documented it quickly with a template. It's interesting you talk about, what's a noteless future look like.
yeah,
Templates don't sound like a noteless future, but I mean, is it because you have to bridge the gap of the two?
yeah.
Is that where, and then people are used to seeing the template? Is that kind of where you're at?
Yeah, no, it's a great point. We have done a ton of testing internally and with a lot of our users about what templates provide. In some ways, yeah, it is a bridge. It's a term providers are familiar with when they document, especially those who've been practicing for a long time. They have a certain way of viewing data that is comfortable to them, it's familiar, and being able to replicate that is hugely helpful. I think the next step of what we're using templates for is as these AI tools get better, it almost can be used as a set of short-term instructions for how do I want to see information.
Mm.
To again use an example, let's pretend we're managing hypertension. I have years of data now that I can see for your hypertension, medications that we've tried, blood pressure ranges, social factors that impact it. If I'm a cardiologist, I may want to see information about your hypertension in a certain order, in a certain flow, a certain relationship, so it's quick and easy for me to summarize it. If I just let these AI systems read that information and output something, it's going to not match my style. It might be overly verbose, or the logic may not be the way I think about these patients. And what a template allows us to do, and we're borrowing this term from the past because it's familiar and something a lot of clinicians understand immediately, is how do I want to see the data on my patients? Maybe me as a cardiologist, I want blood pressure medications before blood pressure range, before social factors. And maybe my peer cardiologist wants it the other way. But templates allows us to apply just a filter or a view to the same information, customized to me, so it always matches how I think, how I process. It's always easily ready. And with these AI tools, it becomes increasingly powerful to really modify the view to exactly what I want without having to change the data or go looking deeper to find the stuff I want to see.
I mean, it's interesting. I don't know if you meant to imply this, but it almost sounds like the template informs the AI of what needs to be documented for this visit in general. So I think
Yeah.
that's interesting. One of my last interviews, they
Hmm.
said a lot of doctors rely on the template as almost their checklist of
Hmm.
things they need to check and evaluate and document. And so it is interesting to see how this is going to evolve because it reminds me of the paper chart on the door.
Hmm.
Once we got rid of the paper chart, we were like, oh crap, how do we know the patient's ready? And we had to work through, we forgot all these
Excuse
dependencies.
me, can I? Oh, okay, okay, thanks.
Yeah, well, like we were dependent on the paper chart was there, and
Yeah,
so we knew, oh, the patient's there, right? And we had to like, well, now it's not there. So what do we do? It's kind of the same, if we get rid of the template, what do we do, right? Well, what's the new workflow? I think we're going to discover some of those. So I think that's interesting.
yeah,
Cool. Well, I think everyone's questions always after these interviews is where can I get a demo? I need to try
sure.
this. I want to see it. So where can people go to learn more?
Yeah, so the easiest place is to go to our website. Our website is riverrecords, one word, .ai. We have a link to a free trial. Anyone on the website gets 14 days totally for free, no credit card. You can sign up for a free demo with any of us, including myself, to walk you through it together. Or, of course, you can email me directly, alex@riverrecords.ai. I'd be happy to sit down, show you how it works, and see if we can get you signed up.
Awesome. Alex, I appreciate you taking time. I know you're a busy doctor seeing patients and other things. So I appreciate you taking time to talk with us and share what's happening with River Records. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting applications. Thanks, Alex.
Thanks so much, John. It's great talking to you.